Hi, so I'm Rosie. I was lucky enough to be part of the lived experience group with Nazar. And I also actually helped to collaborate on the Cochrane report, which was really exciting. And in my personal life, I'm a psychological wellbeing practitioner, so I deliver cognitive behavioural therapy. So in our first presentation of the day, we'll be exploring the value of therapies and treatments to assist survivors. We'll also draw attention to the potential factors outside of the content of treatment itself. This includes relationships with the therapist, peers in the groups, what sort of group settings they might access, the level of support from their family, the types of trauma a person might have experienced. So we'll explore how these factors serve to enhance or reduce the benefits that people derive from treatments and interventions that they experience. So now we'll play the first of two videos. These contain the actual words from Mozart participants spoken by our colleagues, mainly from our lived experience group.
Quite quickly, I spoke to a woman and she managed to sort 12 sessions of trauma therapy. It was pretty quick, pretty amazing. It was a proper breakthrough and then it all just stopped and I was like, whoa, what do I do now? I felt a bit lost.
The EMDR therapy for PTSD completely changed my life. I was having flashbacks several times a day. Now I don't break down and cry every day, and I can go out and not think about it. I did the one where they tap. It was difficult, obviously, having to think back, but no worse than having a bad day. It got easy after the second and third session. I was seeing the benefit.
Incredible, absolutely amazing. She works spiritually, so we massively connect on that front. She's just so easy to talk to, and you know she's taking it in and listening rather than taking a medical route. I'm over scales and checklists. I sit with her and we do meditation. The medical way is not for me. I've suffered with mental health since I was about 12, and I've wasted a lot of my life with the wrong people, wrong environment, and wrong medication.
Therapies through the NHS wasn't really what I needed, and it took a long time to get through all the gatekeeping. What I had was too specific and targeted and not general enough. I found CBT frustrating, and it wasn't relevant to what I was thinking.
Our therapy group was one of the highlights of my year. I really liked it. Each week, we focused on a different medium of art. The people who facilitated it, an artist and a counselor, did it perfectly. They created space for us women, for us to gently interact.
What they instantly thought was CBT, which is not appropriate for someone with Asperger's. My friend could see it was winding me more up, so I stopped it. It didn't work for me.
I found the person absolutely amazing. I went in slightly daunted, but she was incredibly sensitive. We never had to address the main issue, which was my childhood sexual abuse, just the repercussions. She was really insightful.
What I would say about the NHS group that I accessed was that there were other people who had experiences, but these were with strangers, whereas mine were with people I knew. Some of what the other people said would uphold the myths that are out there, and although the counsellors did challenge them, it had already been said.
One thing that stands out, I only had sort of 3 counselling sessions with my counsellor, and she was very focused on the court case and my state of mind. She seemed to really understand me after 3 sessions, and she recommended a book for me. Honestly, this book has been no end of help to me. I think it's really good that she's not just sort of focused on the rape itself, because I kept saying to her, it's like all your past demons come together. So we have been talking about life in general and my childhood. So not having the narrow filter in place is extremely helpful.
I've had to sort of justify past actions, which is quite unhelpful. There was a psychiatrist, my first meeting with her. I've been previously raped, and she asked why I didn't say anything or stand up for myself. I found it a very surprising and hurtful question. The good thing about it is the actual facility, and the way they run things is very good.
The woman I dealt with the whole time's beyond incredible. I never felt rushed through the process. Like, you have a limited period of time to figure it out. They were turning up for me and held that space really well. She would look at new techniques we could work through. I'm a yoga teacher, and she did a trauma-informed yoga course. She tapped into what was relevant to me.
The counsellor was definitely a great counsellor. She was incredibly non-judgmental. Because I only had 12 sessions, I felt pressure to get everything out. By session 8 or 9, I hadn't even talked about the events, and I was told I had to because we only had 3 sessions left. I felt that the choice had been taken away from me, although I did appreciate the counsellor.
So doing good research is vital in identifying effective ways to meet the lifelong needs of survivors. We looked at research from around the globe to get an overall picture of what global research says about interventions for people who have been exposed to sexual violence and abuse. When we say psychosocial interventions, I mean the psychological and the social therapies and treatments that people may encounter when they seek help. The MESARC team did a Cochrane review, and this means that it's basically a type of rigorous methodology for gathering different kinds of research and making sense of it. So the results of the 36 studies were combined and analysed, which we'll be talking about now. So we did 2 kinds of comparison. The first one compared any psychosocial intervention to a control group to see if there was a benefit for mental health and well-being. We looked at outcomes for survivors in the days and weeks after treatment, and we refer to this as post-treatment. And the main outcomes were post-traumatic stress disorder, or PTSD, depression, dropout from treatments, so ending treatment early, and unwanted effects. There was a second comparison where we looked at trauma-focused interventions and non-trauma-focused interventions. So let me explain what I mean. Some interventions, such as eye movement desensitization reprocessing, or EMDR for short, involve confronting feared memories of the sexual trauma or cues that are associated with fear at the time of the trauma. And we refer to these collectively as trauma-focused interventions. Other interventions do not involve this trauma focus, and we refer to them as the non-trauma-focused interventions. In its research, they included stress inoculation therapy, supportive counselling, presence-centred therapy, as well as emerging interventions such as trauma-sensitive yoga. We looked at the same outcomes here, so the same outcomes as the previous group, which were PTSD, depression, dropout from treatments, and unwanted effects. So these are our participants. The majority of them were women in their 30s. We had, as you can see here, 3,965 lovely participants in the Cochrane review across all the 36 studies that we combined. So the majority of these were the women in their 30s, and there were only 27 men across these studies. Most of these studies were from the USA, but there was actually quite a diverse sample among the women, with 60% of people from a black or minority background. There was a high burden of trauma symptoms at entry into the studies, and these participants accessed a range of interventions. They can be categorised into cognitive behavioural therapy, behavioural interventions, and low-intensity psychosocial interventions. What I mean by low-intensity psychosocial intervention is things like psychoeducation, videos to prepare people for forensic exams, and several community interventions where emphasis on sexual violence and abuse was secondary to other social or health concerns, such as HIV. These approaches tended to require less specialist training for staff and were relatively accessible. The three categories included new types of intervention, as well as trauma-focused and non-trauma-focused intervention. So what we found across these studies was there was a large reduction in PTSD and depression symptoms. There was also a large reduction in anxiety and distress levels. There was no difference in unwanted effects, which were at around 21 events across all the studies. However, the studies did not actively assess experiences of harm in people who left studies early, so they were discounted when they left the studies. So what we found in the trauma-focused versus the non-trauma-focused interventions was that there was little difference on post-treatment outcomes. Both showed improvement. However, 3 months later, people who had trauma-focused interventions continued to improve at a greater rate than those who had non-trauma-focused interventions. However, again, more people left the trauma-focused interventions early, so not completing treatment. We found that this was a third compared to a quarter of people who accessed non-trauma-focused interventions leaving early. There were no difference in detected adverse events. But on follow-up, people who have dropped out of interventions early was poor. The problem has improved in recent research, and we'll now transition onto another set of voices. Please note the shift in focus from hearing about the types of interventions to other features of importance to survivors.
Hi, my name is Gemma Honeywell. I'm the CEO of The Greenhouse, which is a specialist support service in England, Somerset. I'm here to present the findings of our second Cochrane review, and it's been my joy to work with the ESOP team for the last 2 years as a research fellow at the University of Boston. So I guess as we've just seen from the voices that we've heard, there's so much more to an intervention in being effective than the content or even the mechanisms or the tools that make up that service. Clinical improvements don't always signal an absence of harm or a significance of satisfaction. So in our second Cochrane review, which was a qualitative synthesis, we pulled together the findings from a large number of studies. I think we screened about 20,000 in the beginning, didn't we? And we pulled together the findings of a select few that were really robust to understand how and why different psychosocial interventions were effective. The review included around 300 survivors' voices, 19 family members or partners, and 60 intervention facilitators. The majority of survivors in the study were aged between 5 and 69, and we did find that most studies actually didn't collect data around ethnicity. The types of interventions that we included in our second Cochrane review were really wide-ranging. So some of the studies that were included were trauma-informed CBT, EMDR, compassion-focused therapy, faith-based interventions, alongside a real range of psychotherapies, art and drama, dance therapies, trauma-informed yoga, and what will always be my personal favourite, Reiki. What were we trying to find out? We were trying to find out how and why different psychosocial interventions are effective. And what we found in general when we pulled together the themes from the key messages of the research is that while the different psychosocial interventions differ in style and approach, of course there are so many varied interventions there, overall they help survivors in many and multiple different ways. So the first was around improving our understanding of trauma and its impacts. Interventions that were accessed help survivors to re-engage with a wide range of areas in their lives. So not just the individual skills within the therapy space, but actually supporting with coping skills for going back into finding employment or being part of the wider community. We also found that there were improvements around interpersonal functioning or building relationships with people. Having access to supports in this way helped survivors to have the confidence to build new relationships with people. And across interventions, we also saw improvements in mental health, mood and physical health. So those are some of the outcomes of the services that we looked at. But what are the features that make up an effective psychosocial intervention? So the big one, of course, was the therapeutic relationship itself. So positive therapeutic relationships were perceived to be ones which were trusting, non-judgmental, and enabled survivors to feel safe and empowered. Where a positive therapeutic relationship didn't develop, survivors reported that they didn't feel safe and often struggled to derive benefit from the interventions that they accessed. Some survivors also felt a sense of loss if their facilitator left. Readiness was absolutely critical for engaging in psychosocial interventions. And we found that may be actually as important as the intervention content itself. Survivors said that not being prepared for commencing or ending in an intervention undermined the potential benefits that could be received from it. Empowering survivors and their supporters to make decisions about their intervention, enabling choice, was a critical step in recovery. This approach requires allowing survivors and their families to make choices about the range of interventions that they can access which would be right for them in their way, and giving survivors and their family clear information so that they can make those choices. Supportive provision prior to and after the intervention itself was also very, very helpful. Trusting relationships with peers participating in group interventions were also really, really important. Survivors described a trusting relationship with peers as really central to the healing process. Being with other survivors, having shared experience is absolutely critical to enabling change. And facilitators noted that survivors who've experienced re-victimisation and multiple traumas and complex trauma often found it hard to achieve stabilisation in the early phases of working with frontline services and psychosocial interventions, and this was particularly the case for children and young people. So professionals felt that it was really beneficial to have more flexibility to be able to work with carers and the family to address any wider problems and stabilise the home environment before providing that support, to help the person prior to and alongside interventions. Because when interventions are not appropriate, alternative support or provision should be considered. So going back to that key point around choice.
So, in a take-home message, and actually you have some things to take home. So in your packs, we've got these three briefings or three summaries that we've produced from these findings. And one of them is for survivors and their family members and friends and people who are supporting them. Another one is for people who are commissioning these interventions and services, and another one is for people who are providing and delivering these services. So there's the three different audiences. So please have a look at those, see in your own time afterwards. But the key sort of messages would be, the study generally showed in both the quantitative and the qualitative review that the interventions were effective, and they showed that a wide range of interventions were effective as well. So it really underscores the importance of enabling disclosure and providing access to interventions in the aftermath of sexual violence and abuse. In the qualitative studies the qualitative studies often ask people who've completed the studies to take part, and they were the people who took part. And in the quantitative studies, as we said, there was an absence of interviews with people who've dropped out. So there's a limitation there in that we don't really understand that side of things. But generally speaking, we found from the studies that there wasn't any additional harms created, if you like, from taking part in the interventions. However, there were some areas where there was some potential for harm. So in not enabling survivors to have control over when they started and when they ended interventions, and that was highlighted as being particularly important, both in terms of both elements, starting and ending. And then when survivors did not feel comfortable or safe, and that whether with the intervention provider themselves or within the group that they're in, they were also really important. And sometimes when we do research, we think that dropout from an intervention is a bad thing. It's often noted as something that's kind of a negative. But what these findings highlight actually is it's not no point in sort of forcing someone to stay in an intervention that's not right for them. We should be enabling people to make choices if that intervention at that particular time is not right, or they can't form a relationship with that particular treatment provider, then giving them the opportunity to restart again with somebody else or choose a different type of intervention is really important. So therefore that means as well, because of different types of interventions, and as we've already heard, some people preferred some of those clips that we heard. The talking intervention was really great for them, but for other people it wasn't. Some people really like yoga. There's some of our interventions that we looked at were very faith-based interventions. Some of them were groups where maybe if you've got a large number of women attending the groups and it's a male survivor, then that might not be appropriate for them. So what it means is that there needs to be, in an area, there needs to be different types of interventions and flexibility, and they need to run quite often and regularly so people have time, opportunities to choose to start the intervention when it's suitable for them. Our findings highlighted that co-producing and having survivors having a role in treatment provision was really important. And that's important because it kind of it helps to balance the imbalance of power that you would get normally between treatment providers and commissioners and the survivors themselves. But it also means that it's much more likely that the intervention itself is more suitable for them, but also they can highlight the other aspects. For example, we found that one of the findings was if the people who are on the reception, like you all had the reception today, if they weren't trauma informed and they did not respond in the right way, then that could completely undermine the intervention before somebody even got to receiving the intervention. So it's really important to get that kind of feedback. And finally, time. Time is important because you need to choose the right time for the intervention. And during the intervention, people need time to build that relationship. They need time to sort of stabilise in terms of their own feelings and their own mental health. They need time to cover all of the things some of the quotes said about how they felt rushed. So they need to have time in the intervention. And then also to end the intervention at the right time. And there needs to be kind of like, as we said, lots of provision so that time and that flexibility can be built in. Okay, thank you very much. That's what we're going to take a question. Has anybody got any questions? We've got an opportunity for one question, haven't we? Raise to put your hand up. Oh, there's a question. We've got mics going, so we've got microphones on. Standing up.
Hi, I'm Dr. Bilakanti from Integrated Sexual Health Services Commentary. Sorry if I didn't understand about the Cochrane 1 and Cochrane 2 review. How did you choose to put a study in a Cochrane 1 or Cochrane 2? Is it because of quantitative and qualitative? And what were the differences in inclusion of that particular study into that review or this review?
So you're right, yeah. In the quantitative, what we call roughly the quantitative one, it was studies where they'd done something like a randomised control trial. So they had taken some participants and they'd randomly allocated them to receiving an intervention. Often it was a control group, or they might have had one type of intervention and then another group had a different type of intervention. So they were very much around assessing the interventions in terms of that aspect. Whereas the qualitative review was studies where they spoken to people who had taken part in the interventions, or they were people who had delivered the interventions, and also people who had supported the survivors and their family members and their views. And so what we'd hoped when we started actually was that there would be some interventions where we had both those elements. People had done the randomised and also asked the participants about their views. And actually we didn't find, there was only 2 studies that we found that the the elements that they'd included in the qualitative bit didn't quite meet the criteria for us to include them in our studies. So we'd hope that there would be much more of an overlap, but there isn't. But they still, they complement each other. But that's essentially how they were determined. More on those elements in terms of whether they were quantitative or qualitative, rather than a type of intervention. So as long as it was a psychosocial intervention, we had those studies, they were included. Yeah, so the quantitative study focused on interventions where the person, for people where the sexual assault or the rape had happened when they were adults, whereas the qualitative one, we included studies whether it was a child or an adult, so there were some more children in the qualitative studies than there would have been in the quant one.